Hello everyone and good afternoon. Sorry we're a few minutes late, a few technical difficulties which have now been ironed out. So today we are joined by Sarah Holt, who's going to be talking about COVID rehabilitation and the BTE Primus. So Sarah, thank you very much for joining us today. So the format is basically going to be Sarah's going to talk through a couple of slides and then we're going to go to a Q&A session. So please, if you've got any questions, put them in the Q&A section and I will come around to it towards the end of the presentation. So are you ready to go, Sarah? Can you hear me? No. One second. Can you hear me? Okay, we can't hear you now. Can you say something, Sarah? I can't hear you. No, still can't.
Can you hear me now?
Yeah, perfect.
Oh, can hear myself now though.
No, we can hear you.
That's good. Sorry everybody. Technical issues. Oh, sorry, did you say you wanted me to go ahead and do it?
Yeah.
I didn't hear anything. Sorry everybody. We have issues in some sort of IT black hole here, so we have issues. We've moved rooms about 3 times, so hopefully you won't lose me, and apologies if you do. So Andy's just asked me to talk a little bit about what we've been doing with COVID rehab using the Primus. So I'm Sarah Holt, in case I'm sure he's probably said that, but I couldn't hear him. I'm an OT working at the University Hospitals of Derby and Burton, but based at London Road Community Hospital. We've had a Primus for about 4 years now. We've used it for various things, all sorts of projects, as well as our everyday normal stuff. So if anyone has any questions about anything else that we do, I'm sure we may have a little bit of time at the end. But the purpose of today was just to talk about COVID rehab. And I think what's become quite apparent over the last, certainly in the last few months actually, is that there are people all over the country who are struggling to facilitate rehab for COVID patients. So I don't know what everyone's background is, but you know, obviously people are working within long COVID assessment services, but struggling to have an environment in which they can actually do rehabilitation. So we're not a long COVID service, we're not a COVID service at all in theory. We were asked in around about April last year if we would consider doing vocational rehab for patients who've had COVID, and very quickly started that pathway. And very quickly realised that the Primus would have a part in that process, and certainly would make things a lot more efficient and a lot easier for us to manage the sheer numbers of people that are coming through. So the sort of things we've done so far with the Primus is using it to form part of a baseline assessment, and I'll come on to what we're considering doing going forward, and that's going to be very much part of it. So trying to establish somebody's physical functional capacity in that at the beginning of their intervention with us, so that we've got something to refer back to in the future. What you'll find as we're talking probably is that this isn't massively different from the way that you might use the Primus in normal circumstances. It's just applying it to COVID. One of the things, as I'm sure everybody else has found, that we were restricted on the face-to-face interventions that we were allowed to do. So it just allowed us to get through more people and to understand how they were presenting when there wasn't a lot of background for us to work with. So we didn't know, as I'm sure you all know, how these people were going to present. So it really helped us in that assessment process. So we have been asked to do some functional capacity evaluations. You know, some people now are kind of 12 months down the line, if not a little bit more, from contracting COVID, and it starts to bring into question then capability. Do we need to look at redeployment? Is somebody capable of going back to the job that they did before? So I've used it quite a bit in that sense, and also just for ourselves prior to workplace assessment, potentially trying to establish somebody's functional capacity in relation to their job. So as always, we use it as part of rehabilitation. So again, I think it's given that objective information for patients that perhaps don't feel like they're particularly improving, and often they actually are. So when we assess them on the Primus, it's clear that there is some improvement, and that's really important, I think, for motivation and moving forwards. So it allows us to monitor their progression, as I say, and also to give us some objective outcomes. So outcomes is important with COVID, as it is with everything else, really. So having those very objective outcomes has been really useful, and it's something that we're planning to progress as we move forward. And then to evaluate specific work tasks, again, exactly how we would always do. So if we've got somebody that perceives that they're going to struggle with something in particular, trying to simulate that as closely as possible and evaluate things like lifting, push, pull, all those sort of classic things that we might need to do. It's been invaluable. And I don't know whether anybody else is, but we do a vast amount of AHP fit notes in our department. So having that really objective data is really useful when you're filling in AHP fit notes. For those of you who haven't done them or haven't seen them, you don't get a lot of space to get your point across. So anything that will give you the opportunity to very clearly and succinctly give them information that is going to be more understandable to the layperson, I think is really useful. So going forward, we've been approached, we've been working with our long COVID service now for, since they started in around about September time, but certainly more closely working with them in the last few months. What's become very apparent is there is a vast amount of people suffering from long COVID who do have return to work issues, and return to work is a big focus of their rehabilitation. So as we're not, I should have probably filled you in a little bit on the background of our service. So we are primarily a musculoskeletal service. So, we will have our core business to continue to provide, and we're anticipating that we'll get back up to relatively normal levels in the next few months. So at the moment, I think we're running at around about 75% of our normal activity, but we're expecting that to change in the next few months, particularly as restrictions relax, whenever that might be. So we wanted to have some options to move forward, and all the way through this we haven't had any funding to do COVID rehab. We haven't been commissioned as such to do COVID rehab. Maybe had I realised the sheer numbers of people that would come through, I might have thought this through a little bit more, but we just started running with it, and it was successful. We got through a lot of people, so of course then you get more and more referrals. But our long COVID service locally in Derbyshire have told us that since February of this year, they've had around about 500 referrals, and a lot of those patients do have return to work considerations. So they're keen for us to continue to provide some sort of service, and I'm keen that my staff don't hate me for giving them far too much additional work to do. So we're currently working with the CCG to try and look at what we could offer and what sort of cost that would be involved in. We have to bear in mind that as I'm sure with most people, that the county is a large area, and regardless of whether we've got the capacity or not, a lot of people are not going to be in a position to regularly attend for face-to-face rehab, just for the sheer distance that they may need to travel. So from that point of view, we wanted to offer options, and like I say, for our sake and being able to get through patients, we want to offer more than one option. So both options very much involve the Primus, and I think that's really key in the outcomes and getting the data that we'll need, but also being able to assess and advise much more accurately. So the plan would be to try and have a baseline face-to-face functional assessment, some of which will be standardised and some of it patient-specific, depending on the job, depending on the functional requirements. And then we would plan to use the Primus and other equipment to get that baseline data. The plan would be then that we advise them, we give them resources. We've got a huge amount of resources already, but we'll give them resources, a home programme. And at the moment, Jazz, who's my colleague, is working on a workbook. So it's around sort of self-management and people understanding their own work needs, because if we're going to manage them remotely and we're not going to be in touch with them on a regular basis, they need to understand how they can establish their own functional requirements in relation to work and how their current ability relates to that. So we've been running a virtual group for good sort of 7-ish months, I'm guessing. I'm not quite sure on the time frame on that. And it's been really successful. It's allowed us to get to a lot of patients, but if we're going to provide much more of a fixed programme with parameters in place to allow us to get through the numbers, the plan would be to do a restricted number of sessions. So maybe a virtual group of 3 sessions where we can get to around about 20-30 patients all at the same time, and it's very much related to their work requirements. And then we've been asked to consider workplace assessments, and this is something we've always done. And it's hard to quantify because we do it on a needs basis, but so trying to establish the number of people who might need a workplace assessment has been a little bit challenging, because we think that if we can use the Primus effectively enough, then we don't always have to go out and see the workplace in order to establish whether they're fit for work or not. But the option is there for a workplace assessment if that's required. And then the plan would be to repeat exactly the same face-to-face functional assessment after 6 weeks. And then that would generate a report to the employer and to the referrer that's very much focusing on the work capacity, and it would include the data that we get from the Primus. So 6 weeks doesn't seem like a very long time in the long COVID world, but what we're hoping that they'll do is they'll send people to us at the point when they can at least attempt this type of programme. That's going to be quite challenging for the referrer, I would suggest. But, I think even if it means that we've got to then refer them back to the long COVID service and say, you know what, actually, they weren't quite ready for this. We haven't got the results that they need in order to go back to work, and then refer back to us at a later date. We've been trying to avoid face-to-face if we can, but I think without doing that, we're not building into somebody's lifestyle, really, a routine. A lot of people are stuck at home, reluctant to leave the house, and we think that they need to be at the point where work is a realistic option, probably a couple of months away in their minds, so that we can do the bit that we feel like we're best at, because so far we've been given a lot of early stage support and advice in the absence of other services. So we want to get back to what we feel like we're good at and what the point of our service is. So option 2 would build in more face-to-face interventions. So this is for people who, have a job that would really benefit from more regular rehab, or certainly that they live locally enough that it's realistic for them. So again, in many respects, we do similar things. So we'd still do that baseline face-to-face functional assessment. Again, exactly the same. Some of that will be standardized, some of it will be specific. Again, we'll use the Primus and other equipment to get that baseline data. And then the difference being that then they will attend for 6 weeks of rehab. To us, that means that they don't need the virtual group, because part of what we do, it's not led group sessions, it's individualized rehab based on their functional needs. So along with that, they'll have therapists and assistants in that session with them, so that all that advice that they may get from the virtual groups when they're being managed remotely, they won't need, because they'll get that while they're here. And then the intention would be, again, to repeat that functional assessment. So at first I thought maybe that could be on their 6th session and we could fit that into their rehab session, but I think I've had a bit of a rethink on that one. And the plan would be to bring them in for a separate assessment for that, so that we've got that time available to one-to-one to go through everything they need to go through. And in exactly the same way, it would generate a report for the employer and for the referrer, and it will focus on their work capacity and will include use of the Primus data. And like I say, they won't need the virtual group, so that won't necessarily be necessary for them unless they really aren't going to cope with face-to-face, and then we can divert them onto the more remote programme. But of course, they would still have the option of a workplace assessment if we felt that we couldn't get enough information from the face-to-face interventions that we're doing. So just to summarise, the idea would be to be able to get through more patients, to do it as efficiently as we possibly can, use what we can with the Primus in order to get that objective information and everything that we need in a shorter space of time, to offer that face-to-face if it's possible, and if not, have that remote option available to people who either live further away or not capable of face-to-face interventions. But the simple reason for doing this compared to what we've done so far is just to capture as many people as we can and offer them the opportunity for work to be a focus of their rehab. And I wasn't sure who was on the call, but Andy just asked me to put some pictures on, just in case people aren't familiar with the Primus. So this is just a little snapshot. It was these pictures, I didn't have time to do any new pictures, so they were quite specific to an assessment that I was doing at the time. So I had a lady that was an assistant in the eye clinic, and some of the things that they were doing were using an eye scanner, which used a joystick type attachment. So the bottom picture on the left-hand side is how we sort of simulated that. There was a winding mechanism on the scanner, so the picture on the right was for that, and then we used the attachment at the top left when we were looking at how we can consider push-pull of things like wheelchairs from the waiting room and things like that, but also assisting with transfers as that's sometimes required. So we use the attachment there for some static resistance exercise. So in a snapshot, and I'm sorry if that wasn't quite what you were expecting, that's where we're at. That's what we've done so far. And then we've done another webinar in the past with a case study and things like that. So perhaps if you want more about what we've done so far, then some of the, I mean, we can probably send you links to the things that we've done before. For those of you, perhaps some people will know, but we did some videos, myself and my colleague, on return to work post-COVID, and they are all over the place. So they're on the Your COVID Recovery website, longcovid.org, NHS employers, and various other places. So if you think they would be a useful resource, then by all means, let Andy know, and I'm sure we can send you the links to those as well.
Great. No, thank you, Sarah. Yeah, just on that topic. So a few weeks back, I was just inundated with requests for information on Primus usage, and I'm like, where's this all come from? And I had a conversation with all over the place, which is obviously very helpful from our perspective. So just before we go into the Q&A, we've got some questions that have come through. But in terms of those two options that you've given, have you had any feedback on which one is being preferred or from management? You've gone quiet again, Sarah. Still can't hear you. You're on mute now. I can see that's come up. No, still can't. There we go. I can hear you now.
Yeah, okay.
Don't know where that was. Yeah, so just I don't know if you heard my question, but it was just which of those ones, in terms of including the rehabilitation or remote management, which of those has been more favourably received?
Well, we haven't really made any conclusions yet, so I've just offered the options. I think that we've done a bit of both already, probably not in such a fixed way, so we haven't had the parameters in there, and the 6-week thing, you know, it's just been ongoing, and I think they were keen to understand what we've done so far. So we haven't had that feedback. So as soon as I have that feedback, I can obviously let people know. My feeling and my instinct is that they'll probably want a combination of the two, and that will be based on where people live and what they're able to manage. What we haven't quite established is how free we'll be to move from one to the other. So if we feel that someone who has been remotely managed isn't coping with that and needs face-to-face, can we swap them over and vice versa? But I think it was just to be able to quantify it really, and to consider how many people we might be able to see. So at the moment, for our own sanity as much as anything, we've sort of restricted it to 20 of each option per month, which is still relatively high numbers because the patients can be fairly complex in their presentation.
Okay, great. And okay, first question. So what should an assessment look like and how long does it take?
So normally we only have half an hour for a new patient, so that can be quite challenging. But what we probably do is we probably speak to them on the phone, do the subjective, get the history, get a bit of a plan together and a bit of an understanding, and then do this face-to-face bit with the Primus as a separate half an hour. But the plan would be going forward that the intention was that we'd do an hour and we'd do all of that in one go, and that we'd be looking at, depending on how the patient presented, but certainly, you know, your standard things like grip strength, leg strength, you know, we've got other equipment here as well, obviously, and possibly something at shoulder height or above. So a lot of patients are struggling with elevated movement. So probably, you know, only about 3 or 4 standardized things, and then everything else would depend on how the patient presented. But the intention would be to do an hour, and then send them off, like say, for 6 weeks, and then an hour follow-up. And then we've sort of suggested that we'd want at least an hour of admin because the report writing is quite challenging. So that would be the plan for remote management, that it would literally just be 3 hours per patient of cost, I guess, at midpoint band 6, because that would be our average.
Right, okay. And in terms of that then, so how do you justify that with the alongside the other work? I know that's some of the challenges that we've had with other people, but how do you balance that with the existing work that you're doing?
Yeah, with difficulty really, and I think it's been so variable. You know, we do a lot of trauma, we do a lot of elective procedures as well, generally for MSK problems, and then chronic things. And I think they vary quite a lot for various reasons. You know, people aren't doing crazy stuff anymore, so there's not so much bizarre trauma coming through. The electives have been up and down, and I think that's been really hard to predict already for the last year, but potentially will still be hard to predict. So we are looking now at, like I say, going to the commissioners and saying this is how much it's going to cost to continue to provide this service, and the expectation will be that they will start to fund that. So far we've had our part-time staff doing a little bit of overtime, but the only reason we've been able to do that is we've been carrying a vacancy, because I'm sure everybody else will agree, you know, you don't get, there isn't any money necessarily, so it's being creative with what you can do really. And also with COVID, they want this, so you know, if you put a decent business case together, then you know, it should be successful. It's speaking to the right people. We've been very fortunate with the videos and the response we've had from that, to be able to network with a lot of people that we perhaps wouldn't have had the opportunity to before. So I think it's never been shy to approach people and say, you know, if you're doing something like this, what sort of things did you put together? How did you cost it? Because if it saves you, you know, an hour of your life, someone's already done the work, in exactly the same way as we do when we're bidding for equipment. It's sharing that knowledge really, isn't it? And you know, I don't know who you've got on the call obviously, but you know, some services you know, they really want the vocational rehab, but they haven't considered how it's going to be provided. And the people who are working in the long COVID services are very capable of doing it. They just haven't got the equipment and the environment to be able to do that. So I think if we can buddy up with services, you know, I think that would be a really positive thing.
I think one of the things that I experienced over my 15 odd years working with BTE was, over that period, heavy workshops, that work hardening has really declined. This has really highlighted that in terms of this COVID. So some of the services aren't able to offer these services. So I think it's a really good time to start to look at this. And that's actually, in fact, how many premises were bought in the first place, was it's going to replace heavy workshops, which I think a lot of places haven't gone down that route of being able to do it. So I think now is a good time to revisit that. And I think I've had this conversation with several other users that it's just like, there's so many people that would benefit from this, forgetting COVID, but even more so now. I mean, that feeds nicely into the question from Ali, who's asking if you're using the parameters for conditioning as well as assessment in relation to specific return to work. You've gone quiet again, Sarah.
Hang on.
There you go. You're back. You're back.
Do you know, I have to keep clicking on to test the audio and then it works again. I don't understand why.
Yeah, anyway. Keep the tab open.
Yeah, maybe. Sorry, I've lost the question now. Oh yeah, so we are using it for conditioning to a certain extent. You know, obviously there's a lot of talk out there about not necessarily it being a positive thing for long COVID patients to do exercise, and that's why it needs to be as specific as it can be. So really focusing on the work side of things and simulating the very specific activities, rather than just getting somebody in to do a very broad conditioning type program. You know, you can't, my argument would be, I understand that from a chronic fatigue type perspective, but the fact of the matter is, if someone wants to be able to go back to work, we need to expose them to these activities in a controlled way. And that's really what work rehab's all about, isn't it? So, you know, I don't think we can avoid doing that. And I think in some respects, even if it just shows that they're not ready and that there's a lot of things to work on, it's still a very positive process.
Yeah, no, absolutely. And in terms of like cost and time saving, that's a big thing with everything that we're doing. But certainly when you're looking to invest in a big piece of expensive equipment, how would you justify that? Can't hear you again, Sarah. Sorry, it's gone.
Dear.
There we go, you're back.
Oh God, honestly, so sorry. Yeah, so efficiency, did you say, sorry, and saving time.
Yeah, time, how you justify spending the time on this and the investment in the first place.
Yeah, I mean, the fact that, you know, in the end, to be able to offer somebody vocational rehab on as little as 3 assessments is something you couldn't do if you didn't have this sort of equipment to do it. You know, when we've done stuff before, you know, what we don't want to do is we don't want to shoot ourselves in the foot by promising the world and saying that we're going to get this equipment, and because on the back of getting this equipment we're going to see all these patients that we didn't see before, we're going to offer services to people that we didn't offer services to before. You know, it's never a bad thing to look at trends and things that, you know, the trust seem to be particularly interested in, or any charities that the trust are interested in, to get investment. Of course, that's never a negative thing, but I think you just got to be cautious that you're not offering something that you can't fulfill, and that you know, there are times when I'm pretty certain that my staff are not overly happy with me, because, you know, I do see opportunities and I do run with it a little bit, but, you know, I think that you can be so efficient using the Primus, and you can offer a service without loads and loads of rehab involved. If you're not in a position to offer that, don't offer it. It would be my advice, and just look at using it to inform decisions and to, you know, get your baseline assessment, and then use it again to get your outcomes at the end, or to see if that progression is being made. If that's all you're in a position to offer, then there's nothing wrong with that. You know, if you can get involved with things like treating staff, that's always a really positive thing. Well-being of staff is a massive thing at the moment. You know, if you can offer it as a potential tool for research, that's a really positive thing. So it doesn't always have to be about you and your service setting, you know, giving yourselves a massive headache by increasing your workload too much and in an unachievable way. So, you know, it's using it for outcomes, using it, you know, I don't know, again, I'm not sure if we've got physios, OTs, whoever on the call, but, you know, it's not a case that, yeah, a lot of the time in this country, OTs are the ones that are using it because of the functional element to it. But actually, you know, it doesn't mean that the physios can't use it. It doesn't mean that it's not, you know, they could use it for their outcomes as well. They don't have to use it for rehab, but they could use it for strength testing and outcomes as well. So it's thinking about what you can do without making the problem so much worse for yourself.
Yeah, and you mentioned there about treating.
Can you hear me?
Yeah, I can hear you on this one. So in terms of occupational health within the hospital, how many, a lot of NHS staff have been exposed to COVID. I'm sure you see that as well. How do you have a big percentage of internal occupational health that you're managing?
Sorry. Can you hear me?
Yeah, can hear you.
Sorry, go on.
So yeah, occupational health. So do you see a lot of staff members coming through as well as the public?
Yeah. So in the first probably 6 months of doing COVID rehab, for instance, 65% of the patients coming through were staff, simply because a lot of people contracted COVID and have developed long COVID. So, and we always have been involved with staff, and we've recently had an OT join our occupational health team for the first time ever, someone actually working for occupational health. And, you know, she comes and uses the Primus to do assessments, because it, again, just to be able to give you that information, you're often asked to do workplace assessments in that type of job. And it's not, you know, if we don't understand their functional capacity before you go into the workplace, often you'll find that it's hard to do that workplace assessment because you haven't got the background information. When they're talking about their difficulties, you haven't got any objective data to base that on. It's just entirely subjective. So she comes and uses the equipment quite a lot. And I think that there's a lot to be said about occupational health departments having their own Primus, because essentially they can do so much in one assessment with that piece of kit. So, you know, we do treat a lot of staff generally.
And in terms of that then, so from that internal, how does that work for, again, you're taking on, is that something that you would normally manage occupational health for your team?
We don't work for them. We just always have provided a support service. So, you know, we are in a corridor with our MSK physios and they take self-referrals from staff. But, you know, we've always taken referrals from following on from workplace assessment or functional capacity assessment where there's identified as an issue, so that we, you know, can provide the rehab. You know, one of the things that a lot of people can assess staff, and they can assess in the workplace. and they can do a one-off functional capacity assessment potentially, but what they can't do is offer rehab. So, especially if you use it in conjunction with a functional capacity, using the parameters with a member of staff, assess the level of ability, use it for rehab, and then reevaluate after a certain period of time, with work in mind and understanding what their job involves. You can't beat that sort of information, and you'd struggle to get it any other way, really. But we always struggle to just generally manage. We take referrals from so many different sources, and there's so many variables, so many fluctuations that I'm sure everybody else is the same. It's always hard to manage that. But I think being clear about what you can offer, one of the things that's come to light quite a lot with COVID patients is just making sure that you empower them to have conversations with their workplace. A lot of them are struggling psychologically, and they want you to hold their hand an awful lot, and they want you to have those conversations for them. And I strongly believe that as therapists, one of our biggest roles is to try and empower the patient to have those conversations themselves. But then if we can give them that objective data to go along with those conversations, that's often a much more comfortable conversation for them to have. So it's trying to empower them to do things so that you don't have to. Otherwise, you could spend a lot of your time having those correspondence with the workplace, writing reports, doing workplace assessments, because they're not able to have those conversations themselves. So, some of it's about putting in parameters so that you don't give yourself too much work to do, but some of it is about empowering the patient to then have those conversations with that data that we've given them so that you don't have to.
Yeah. Yeah, and in terms of the patient feedback then, so how do they react in terms of doing that? Again, certainly from that COVID perspective, do they engage well with the data, the actual assessments that you're doing?
Yeah, I think it's a really positive thing, because I think a lot of the time, like I said earlier on, they don't feel like they're getting better. And sometimes they will have setbacks. That's one of the biggest themes on our virtual group, is managing setbacks, and we're working with our local chronic fatigue service, and that's quite a big thing that they address normally. So sometimes what it shows is that despite the feeling of a setback, actually they aren't necessarily any worse when they're doing their rehab. Whereas if you just had gym equipment or other equipment that didn't give you that feedback, I think that they would still feel quite negative about the process. But because they can show improvement, it works with all patients really, but certainly with COVID, because it's such a weird thing where the abilities fluctuate and they do have these setbacks. Being able to show that either it's not necessarily got any worse, in fact it's got better, or it's got a little bit worse but it's not as much as you think, will stop that setback from affecting them quite so much psychologically.
Yeah, no, it's really interesting. I mean, like you say, objectivity is helpful in a number of different areas. The parameters have been used for a number of years out there. In terms of that remote management then, have you been operating with both of those options at the moment? Have you found one? I guess the one with rehab is obviously beneficial if you can offer that as well.
Yeah, I think the advantages of the virtual group is you can capture so many more people at the same time. And if you're just bringing them in for an assessment every now and then in terms of your management of numbers, it's great. I think the downside is that one of the things that people are reluctant to do with long COVID is that they don't really feel that confident about leaving the house. A lot of healthcare professionals, not so much now, but certainly earlier on, didn't even want to come into a healthcare setting because, there was a lot of anxiety related to that. A lot of people feel pressure, and it's not necessarily coming from external sources, but internally, to get back to work and to get back to that hospital setting. Whereas in their mind, a lot of psychological trauma is attached to that type of setting. So I think having the virtual group, it's brilliant. But the fact of the matter is we want to get people out of the house. We want to get them into this sort of environment. We want them to be face to face with other people, because that allows them to move forward, I would say. So I think having both has been brilliant. And I think going forward, having both will continue to be really good for the patients and for the staff. And I think if you can do both, then I think that gives you options, and then you're responsive to the patient needs, not just what you perceive or what you've been commissioned to do. If they give us that flexibility to continue as we are and have the ability to move, to decide on the option or the plan ourselves, or certainly to be able to move from one to the other, I think ultimately that flexibility will make it more successful. But I think if they go for one option or the other, when I keep saying they, I mean the commissioners, then we can make either one of those work.
Mm. Have you had any initial feedback from the commissioners on that?
No, it literally was just like in the last week or so. So I haven't had anything yet, but as soon as I do, I can get it out there if it'll help people, and I can certainly share the business plan that we did. You know, obviously it'd be helpful to wait and see if it's successful. I don't want to share something if it's not successful, but you won't thank me for that. But certainly if it works, then I'm happy to share that.
Yeah, great. No, that's really good. No, I really appreciate your time on that. So finally, what would your advice be for other places? So on this call, we've got several primary students already who are looking at upgrading their system. And we've also got people that don't currently use it, but are looking at how they can develop the service. What would your advice be to them?
I think if you can get one, it's literally changed everything about what we're able to offer. You know, like I said, we've always done vocational rehab, but having that ability to provide that very objective assessment, taking the guesswork out of situations is just been great. And it was so easily adaptable to something like COVID. So I think it's, you know, I'm very strong believer in recognizing the contribution that we're able to make, and communicating that. That's something that I feel really strongly that, you know, therapists generally and specifically for me, OTs have got an awful lot to offer this situation. But giving an OT or a physio an office without any equipment or any facility in which to actively change something is only half of the story. So I think it's great that therapists are involved in long-COVID services and things like that. But if you don't have a facility or equipment available to you, then you're never going to be able to do it to the same standard, you know, and really focusing in on what makes it more efficient and the outcomes you can get from a piece of equipment like a Primus. It is the way forward, really. And always very happy to talk to people, email me, whatever, if you want me to help in any way. But I think it's about believing in something and believing in what we can contribute is absolutely key. I'm not sure if I answered your question then, really.
Definitely, no, you have done. I think, yeah, I think that's the thing is really having belief in what you're doing and knowing that it's worth asking the question on these things. We know money's never freely available, whether it's NHS or any areas. So I think the main thing is, from our perspective, we're really happy to help with business cases using success stories like yours, Sarah, and the other ones that are out there. But no, I really appreciate you sharing your story. And if you can update us, maybe it's with me or writing a blog for us in terms of how you get on with the commissioners, I think that would be really helpful to share with everyone else, because there's been a huge, from your social media, there was just a huge wave of interest, not just in this country, but across the world. So great to see that it could have.
Yeah.
So no, thank you very much for your time, and thank you to everyone for joining. And we'll give you the updates as and when Sarah gets that, and anything else that's relevant. But again, Sarah, thank you again for sharing your time.
No problem.
Thank you. Have a good afternoon. Bye bye.